you very much, Gemma. Actually, Valerie, do you want to say a couple of words about the future pandemics before we start, just so everybody's on the same page, the challenges, issues?
Oh, the challenges. Well, yeah, I can do. The idea is that coming out of, well, the future pandemics workshop specifically, but really everything we've done so far, we wanted to try and get some real sort of tangible output from the program. And we found this idea of having challenges papers has worked in the past. And basically we've tried to divide the area up into topics. That's very provisional, and there are all sorts of overlaps and so on. But so this one is on NTDs, I think. But the idea basically is to think about the challenges that are up there now going forward for the next 5 years, maybe 10 years. Challenges mainly for modelers, broadly, you know, right from maths through stats and so on. But the challenges, they might be for new research students or postdocs or whatever, but things that we think would really put us into a better place in a few years' time for the next pandemic than we're in at the moment. So it could be anything from sort of lessons learned, bits of theory that need to be developed, bits of data that need to be collected. It could be all sorts of different things, depending on which of these things we're in. But the idea would be to have quite focused challenges, and then to have maybe on each challenge a long paragraph or up to a page, but not a whole paper, but just something which sort of says what the challenge actually is. And so when these are collected together, you might have 6 or more people co-authoring the paper, but each individual challenge would be taken on by a couple of people or something to draft and then put together at the end. Deirdre is nodding, but it might just be that that's how she walks, you know.
No, I'm nodding. I'm nodding. That's a great summary. And the thing is, so for those of you who don't know, there was a set of papers in epidemics from the 2015, and that's how I've roped in Jess and Petra, because at that time they were doing a lot of work around elimination, which was really interesting. And indeed, they have a special collection in Proc Roystock. Is that right, Jess? As well?
Flow-trans. So it was a
Flow-trans. Oh, Flow-trans. Yeah. So there's some really good stuff there. So, and it's of course, so the theme for this discussion is endemicity or elimination.
Right.
And I guess that's part of the, it's yeah. Very, yes. Well, I invited a load of NTD people because they're the people like it, I know. So, but, and because it's a really active discussion for NTDs at the moment. You know, should they really go for elimination of these diseases or not? Or is it worth the effort? So yeah, I don't know, Jess or Petra, if you want to say anything about what were the issues 5 years ago and whether you think we've moved on at all in those discussions in terms of mathematical modelling. To put you on the spot.
Petra, do you have thoughts?
Me and my baby being are going to be full of thoughts. Not sure. So last time we were all focusing when it comes to eradication and extinction, like how do we know something has truly gone extinct, stochasticity around there, and I think one possibly interesting thing, especially when we are now in the middle of a pandemic, was that there were interesting discussions many years ago when we were doing that special issue, how emergence of pandemics actually mirrors this extinction process, right? So not necessarily every spark causes a pandemic. So some of them die out, some of them take hold. And also I think on the way to the extinction process, you kind of have flare-ups as well. So there were potentially interesting things, interesting parallels to look at that I don't think we've done at that time. But yeah, I will hand the floor over to Jess.
So I have read some, so it's possibly because I was super ignorant, but I think that Jamie Lloyd-Smith and Seth Bloomberg have come out with some really cool inference tools around the stuttering chains end of it. So one of the, as Petra was saying, and I was partly trying to think while Petra was speaking, so I wasn't entirely listening, was that we were sort of interested in framing it as they should be mirror images of each other, right? So one would think one might be able to use similar tools at both ends. And the challenge is always very much a surveillance challenge. And we also did a lot about, the last mile is the longest, blah, 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 blah. In the, it's exactly the people that are hard to find that will be the people who are left if you're in an elimination scenario, etc. So in terms of, really around modeling beyond, and I haven't done a deep dive on the literature, and I'm sure there's stuff that Deirdre actually probably knows much more about this than we do because of the some of the cool NTD stuff that's coming out. I can't put my finger on anything beyond that Jamie Lloyd-Smith bit. Is that mildly coherent?
Yeah, no, it was absolutely. Has anyone been involved in any discussions around elimination of COVID on this call? Possibly not.
No, not at all for me.
Yeah, it'll be great. And we might do one of these discussions early or late to try and catch some of the New Zealanders, etc. But, how do you know when you have eliminated is an interesting question. So I think that's sufficient framing, and maybe we talk about 2 specific examples and then think about the generalities, if that's all right. Mariam, would you be willing to go first? You're muted.
Sorry.
There you go. No worries.
I can share my screen. I hope you can see my screen now.
Yeah.
Okay.
Yeah, that looks good. Thank you.
Yeah. I will. First, thanks for
yes, perfect.
I think it's good to hear more about elimination. I just talk about some of the issues and some of the challenges we had about elimination of sleeping sickness and how we address them with the help of a mathematical model. This is a work done in the University of Warwick, particularly in the group of Matt, Killing, and Catrock, and as a part of NTD modeling consortium with all the people in different institutes. I will be very short today because I think everyone is more interested in the follow-up discussion. So I first say a brief introduction about the sleeping sickness. It's one of the neglected tropical diseases which is present in Africa and is threatening a big population, and it has the highest prevalence in DRC. It's a vector-borne disease, and it's transmitted to humans by tsetse flies, and infected people go through different stages of the disease, and they would die if they're not treated. There are some programs for diagnosis and treatments of sleeping sickness. There is like one passive surveillance, passive surveillance where people can go to hospitals or medical centers, people with symptoms, and there is also active screening. Some mobile teams go to small villages and check the people just randomly, people who volunteer to participate in these programs. Thanks to the recent efforts, now the number of cases reduced sharply, and actually R0 is very close to 1 for sleeping sickness, actually now it's like a good time to think about elimination of such a disease. Here I just show a plot, this one, and in green you can see the number of cases reported over time from 1940 up to now, and we see that it was high at the beginning, but it decreased around 1960, 1970, and it was very close to elimination, but unfortunately it went up again, the number of reported cases. And if we look at the screening level shown in blue, we can see that it decreased exactly at the time that it started to go up. Recently, there are more screening programs, and the number has decreased again. Goal is set by WHO to reach elimination of transmission for sleeping sickness in 2030. But what we have in data is number of cases, reported cases. For example, we know the number of people screened and active cases found in active screening, and also people who went to the hospital and were diagnosed for sleeping sickness. We don't know the underlying transmission. And in fact, we are interested to know what do reported cases would tell us about transmission, transmission, of course, and or like zero reported cases would tell about elimination of transmission. That's why we use modeling to understand such challenges. This model was developed in the group a long time ago, and it was used to address different questions about the sleeping sickness. It takes into account the details of transmission, different disease, the different populations of humans or the different population of tsetse fly. I won't go into details of the model, but just to show you that it's like a very detailed model to consider everything. And we use this model and available data to fit the model and get the parameters used in the model. Here done at the level of health zone, which is like an area of the population of 100,000 in here in DRC. And using the number of screened people and the number of reported cases, we can find good fits. Sorry, I cannot use, oh yeah, now I can use it. Yeah, we can find good fits and then we can read the number of underlying new transmission for the model. Then we just define elimination of transmission in the model considering a 10-year period, just because we know that HAT is a slow disease, and we just want to make sure that elimination of transmission is reached. So if there is no new cases within 10 years, we consider it as elimination of transmission. First, we wanted to know the relation between elimination of transmission and zero reported cases. For this specific health zone, you can see the probability of EOT given zero cases is plotted as a function of time. It starts from something around 65%, 67%, and it increases over time. That it shows with this probability, elimination of transmission is achieved if there is no cases, no reported cases. And we know there are different strategies and policymakers would like to stop screening if there are like zero cases. So we consider different strategies that they stop screening after 1 zero reported case or 2 or 3 consecutive zero reported cases. Here shown in different colors, and we see that if there are like 3 consecutive zero cases, with a very high chance we reach elimination of transmission. and it can be quite conclusive. This is done at the level of health zone. As I said, the population is around 100,000, but also at the another study from the group showed that this is actually a good measure at the scale of village population. Another challenge that we studied was just analyzing health zones which have shown 0 reported cases for a while, and we would like to know what is the probability that they already achieved elimination by now. So we chose different regions that had very few or 0 cases in the several last years. Here, I mean, these are like 3 health zones shown, and this is number of people screened over time, and these are like reported cases and the underlying transmission in the third line. For the health zone called Mobile, when actually the endemic equilibrium is very low, but at the same time there were not many screening in this region. We see that, I mean, there was also no reported cases, no active reported cases since 2005. We see that there is like around 70% probability that elimination has been achieved. However, with 30% probability it hasn't been achieved. However, for another health zone, Bominang, when prevalence is very high at the beginning, but a lot of effort has been done in this region and a lot of screening has been made. The probability of elimination is very similar to the other health zone, which started from very, very little prevalence compared to this health zone. And yeah, it just said that keeping active screening and the coverage can help to have good and accurate measures of elimination of transmission. The other health zone is something in between, and we see the probability is also in between. I think I planned, I wanted to be short, but I mean, there were the main things I wanted to say, but just mentioning that about another study that I presented before in one of these discussions. Sorry, this slide is not completely done because I wasn't sure if I would say something about it, but we also try to understand, to estimate the probability of elimination and particularly the distribution of probability of elimination for continuum models. And we used a bird model to just estimate the distribution. I wouldn't go into details, and that's it. Yeah, thanks.
Thank you, Mariam. That's really great. Thank you. It actually brings up a lot of challenges around trying to measure 0, but also how to model it. So thank you for that. Does anybody have any questions? There's something in the chat. Oh, okay, especially brilliant. Well, how important is model structural uncertainty in trying to predict elimination, do you think, for HAT? So like different models give really different timelines or probabilities of elimination for the same data.
Yeah, I mean, we recently tried to compare different models. They can be different, but at the same time, they are also very similar. So it's at least the models that we compared our results with, like the models developed in Swiss TPH, or like we have different versions of the model, a stochastic version and a continuum version, and they are like relatively similar.
Yeah. Thank you.
Was it a question, Laura? Because you asked two questions, I assume. Like
I can't remember what the other one was that I asked. I think it was structural.
What is the importance of modeling or something like that?
Oh, yeah. So what I meant was, what's like, if you have different model structures, do you get very different results for this?
The model of fitted to data, probably, I mean, hopefully, if all models are like considering the data, they wouldn't give very different results. However, we see like distributions of elimination year, and we believe it's important to take it into account.
And what in this, so talking about what Jess or Petra, actually, I think it was Jess, was talking about the last mile. So you have this in your models, because I happen to know them, you have this group of people who are less likely to be screened. Mm-hmm. What kind of numbers is that for the models? I've forgotten.
What kind of, sorry, say it.
People who are less likely to be screened. What percentage of the population is that?
Oh, sorry, I didn't mention the details of the model, but yeah, as you know, yeah, you mentioned there are two different populations of humans. One is less probable to being screened, and also more probable to be infected. They are at higher risk. This can be very different from one health zone to the other one. So it's also one of the fitting parameters. For the health zones I showed, I actually don't have the number in mind, but yeah, it can be different. So usually we consider this.
Oh, okay. Oh, okay.
Yeah.
Yeah. Okay. Good. Thank you very much. Okay. I'm gonna move on to the next presentation, because I think both bring up sort of general issues, and then we can kind of have a discussion. I'm also setting up a Jamboard so that people can dump their ideas, you know, try a different technical tool every time we do one of these discussions. I think is obviously an important part of the process. But thank you very much, Mariam, and thank you for preparing that on such short notice as well. Thank you. Appreciate that.
Sorry if I just didn't mention all the details, and it was...
No, you didn't have time. That was fantastic. It was really good. Thank you. That's fab. And so Emma is also from the NTD Modelling Consortium, and is going to talk about elimination of another neglected tropical disease, lymphatic filariasis. So I'll let her do the introduction to that. Are you able to share your screen, Emma?
Yes, I am, yes.
Fab, brilliant. I'll hand off to you.
Okay. So my name's Emma, for those of you that I haven't met before, and I'm going to talk about the elimination of lymphatic filariasis, which is quite a nasty parasitic infection that can cause sometimes irreversible swelling to limbs, as seen in these photos. So it can cause permanent disability. Just like a brief overview of the lymphatic filariasis transmission cycle. So you have, well, there's like the case of the chicken and the egg, really, but if you have adult worms in a human, then when a mosquito bites that human, when they take in the blood meal, they would also take in microfilaria, which are small reproductive stages produced by the adult worms that circulate in the blood. And then in the vector, in the mosquito, these microfilaria then develop into infective larvae, and then when a mosquito with an infective larvae in it bites a human again, this larvae can break out of the head of the mosquito and then burrow into the skin of the human, and then make its way through the lymphatic system and mature to becoming an adult worm. So it's quite a gruesome life cycle, but is quite highly dependent on this development of infective stages in the mosquito. So just a quick thing on elimination theory for helminths. So because the worms in the human host require sexual reproduction to produce these infective microfilaria stages that get picked up by the mosquitoes, in modeling theory, there's this idea of a breakpoint where if you have a low enough prevalence or a low enough burden of worms in the population, then they'll be distributed broadly over the members of the population, and you won't end up with enough pairs of male and female worms in the same human reproducing. So you reach a point where you'd expect to see a natural decline to elimination. And this is kind of demonstrated by this figure over here, where you've got transmission along the x-axis, and then you've got the equilibrium worm load or worm burden along the y-axis. And if you're in a low transmission period, a low transmission area, then it's just not viable for infection to persist, and that's when you get elimination. But if you're in a higher transmission area, then you get this stable and unstable equilibrium forming. So this unstable equilibrium is what we call the break point, and that's where if the worm load is below that break point for that particular transmission level, then you'd expect to see a natural decline in elimination due to the difficulties associated with sexual reproduction. But if you're above this break point, you'd expect it to rebound back to this stable equilibrium. And in the field, in terms of designing surveys, it's assumed that this break point is approximately 1% infective prevalence. So you can be infected by a single adult worm or multiple adult worms of the same gender and not be infectious because there's not sexual reproduction occurring. So it's assumed to be around 1% infective prevalence is around where this breakpoint has been assumed to be in the past, although there's quite a lot of evidence to suggest that it might actually be substantially lower in a lot of settings. And this threshold is then used to design surveys based on diagnostic and age group, which are called transmission assessment surveys, and are used to validate elimination as a public health problem, which is a proxy for prevalence being below this 1%. As well as kind of deterministic extinction of stable and unstable equilibriums, there's also this idea of stochastic extinction. So you could be, I'm just going to switch back a slide, but so you could be in this area here. Can you see my mouse? Just
no, it's just green.
No. Okay. Well, if you're in the area in between the green dashed line and the red solid line, but you're quite close to the green dashed line, then you could due to stochasticity, you could find yourself being pushed over that line. So you can get stochastic extinction even if you're not quite at that break point. And this is just a kind of branching process example of how you can end up with this extinction. So even if the average number of secondary cases is per infectious individual is greater than 1, you might still end up with, if you have few enough people infected, you might still end up with that going extinct. And the way we kind of wanted to look at this idea of the breakpoint and look at the possibility of stochastic extinction and have a look on how dependent these things are to the various parameters that you would, the biological parameters that you would input into the model, because some of these are highly uncertain and some of them are very difficult to measure. So the way we were thinking about this was how many new cases would arise from one infectious case, assuming there's a background 1% MF prevalence or microfilaria prevalence, which is equivalent to infective prevalence. So for one infectious person, you then consider how long will they be infected, how many bites would they receive in this time from mosquitoes. And then you can get a distribution of infectious vectors. And then for those infectious vectors, how long are they going to live? How many infectious bites can they then, well, will they survive the incubation period? Yes or no? And then how many infectious bites after surviving the incubation period, will they transmit? And then this gives a distribution of the number of new adult worms. And then we can translate this to the number of new cases by looking at where these new infections arise and then repeat. So our kind of key question is whether 1% prevalence is low enough. And we get, so looking at just like a univariate analysis, varying these parameters in ranges that can be found in the literature, you can see that you have quite big variation in the probability of elimination on the left, and the effective reproductive number are on the right. So the variables with the highest impact are the probability that if you're bitten by a mosquito with an infective larval stage in it, you will then develop an adult worm. That is highly unknown. And so that has the largest impact, the range of values, but also parameters such as the annual bite rate, so the number of times you'll be bitten in a year, and also the vector lifespan and the worm lifespan are all really important as well. And it kind of also brings up this idea about whether these parameters are uncertain or whether they're variable, and some of them can be both. But for example, this probability that if you're bitten by a mosquito with an infective larval stage in it, the probability that will turn into a viable infection, that's mostly the high variation that we see in the model is because we're not confident, and there's a knowledge gap in what that variable actually is, how that process works, and the biology behind it. Whereas something like the annual bite rate, or the number of times a human in an area is bitten by mosquitoes across a year, is variable and is likely to range due to different dependent factors on scenario and setting. And it's also possible to impact parameters like this or values like this using control measures. So looking at how we can impact the annual biting rate, you can use vector control, so bed nets or indoor residual spraying or larvicides to impact parameters such as this annual biting rate. And because this parameter can vary quite a lot, we can see quite big reductions in it. For example, bed nets have been shown in some instances to decrease the biting rate by like more than 50% in plenty of settings. So you can kind of, this plot on the right shows that if you reduce the annual biting rate along the x-axis, then for the same acceptable certainty for probability of elimination, you could consider a lower, an easier to reach prevalence threshold. So here, going from about 27,000, like an annual biting rate of about 27,000 down to about 13,000, means that if you wanted a 95% certainty of elimination, then that could be the difference between needing to get down to 1% versus 0.5% prevalence. So in summary, our modeling kind of suggests that you might expect 1 in 4 communities with mid-range annual biting rate to rebound for the less than 1% MF threshold, suggesting it's not a sensible threshold for quite a number of settings. Also, the annual biting rate could have a large impact on elimination success, and it's important to think about which aspects of the biology we can influence and which aspects of the biology we can't. But also that there's insufficient experimental evidence for most parameters, which from a biological perspective is a problem, but also from a modeling perspective, when you fit models, it's really useful to be able to tell whether the parameters that you fitted in your models are actually within a sensible biological range, and whether your models are actually saying a sensible thing. So having higher quality evidence would definitely help. And also there's a very high uncertainty in elimination success probability. That's everything I've got. Any questions?
Thank you, Emma. That's really great. Any questions? Okay, no questions. So I think that's a nice example of where we're asked to say something about the probability of elimination when we have not only poor uncertainty about the biology, but also uncertainty about some of these really important parameters. That result of 1 in 4 did not go down well, we have to say, with some of our colleagues. I think that raised some issues. I've dumped some ideas in the Jamboard, some sticky notes. I don't know if anybody else has had a chance to, just from both Emma and Mariam's thoughts so far. So thank you both very much for doing those presentations at such short notice. Anybody, any thoughts arising around general modelling challenges?
I'm afraid I'm going to have to vanish in 5 minutes, but I opened up our previous one, Deirdre, the paper that we wrote all those years ago.
Yeah.
And one of the emphases was on the economics aspects, which I think is really important and an absolute pain in the ass. So I wonder whether that's, I know it's just another can of worms, so I think it's got to be mentioned around these things. And I know Petra's done some lovely work on that. So just to throw that out.
Yeah, no, I think it's really, really important, particularly for COVID, actually. Petra, do you want to say anything about where the mold has moved to since we wrote that? I'm just going to drop off just for a second.
For anyone who hasn't found the sticky notes, by the way, if you look in the chat, there's a link that Deirdre posted.
Oh, I see. So I wasn't, Deirdre, I wasn't really sure what the question was. Is the question how do we
sort of the economics of like elimination, how much it costs to eliminate versus whether you should just put up with endemicity, or the cost of surveillance, or any of those kind of related questions?
From the top of my head, I haven't seen much recent stuff on that, actually, but anyway, I haven't been involved lately. But I know at the beginning of COVID, specifically thinking about like pandemic management, all those questions are interlinked with economic feasibility of any kind of surveillance, any kind of taste and trace, any kind of thing that we are trying to do. And it hasn't been modeled at all. In fact, we were specifically told not to model it. So not really sure what the best way to address it. It's really important, but it's really difficult. Sorry, I can't be much more helpful when it comes to that.
Are there not some startling insights from your PNAS paper, Petra? I know that was a while ago, but sort of thinking about that when you were.
I mean, that was a while ago, but what I'm trying to say is there are some I'll have to go and pick the paper up in a second. There are some abstract. There are abstract exercises, but putting real functions and parameterizing real economical functions in a face of pandemics or eradication, I think, is the hard bit. The insights from abstract economic or utility functions are quite interesting because it pays to prevent, it pays to cooperate, it pays to join the forces regionally. You end up spending less money for better result. But what we are seeing, in fact, is completely the opposite, right? You have this balkanization of healthcare. Everybody does things for themselves. And I think everybody's worse off as a result. But that's kind of, I think that's more better known in, again, theoretical literature. But again, it's very hard to parameterize this in an applied way. To Dashel. I'll be right back.
I'm afraid I'm going to have to drop off too for my next meeting. But Emma and Miriam, thanks so much for your presentations. I learned a lot. I don't know enough about NTDs. And I look forward to catching up on where the discussion goes. Bye, everybody.
Bye.
This is Jasmina.
Hi, Jasmina. Go ahead.
Just to add, I think there is a lot more thinking that needs to be done if economics is to be done properly. I mean, we have a toy model that we started building, but really it's just picking up the costs in order to reduce debts and stuff like that. And that's easy to write up a sort of a cost function. But I think just picking up on what Petra was saying, that I think to do it properly, there are massive challenges of macroeconomics, and I, for once, don't have skills in that, and many epidemiological modelers don't have skills in that. And I think that's the challenge, where a lot of health economics is involved, but I think we need more macroeconomics stratifications like epidemiological modeling to be involved in the field.
Yes, I think that's a very true statement. And maybe we, even though we did obviously feature it 5 years ago, I think it is worth stating again. I think there's a real issue with COVID at the moment, that we don't know what is the function we're trying to minimize by these interventions, let alone what's the cost of an intervention at a population scale.
I'm just admiring Petra's baby. Hi, Petra. Oh, you're muted, but that's
super
fine.
cute.
I'm saying sorry, I'll turn it off. I got
No,
sweet.
I'll turn my video on because I haven't done it yet. Hello.
Hi.
The other thing I wanted to make a point of was, is there going to be space in here to sort of give examples of endemic diseases and how we deal with that? Which would be, for example, I mean, malaria and chickenpox kind of come to my mind as examples where, chickenpox is sort of occurs once in a while, and, there is a vaccine against it, but a lot of the time we just let it be and go through the system. And malaria is endemic in certain parts of the world. So that would be a challenge of sort of thinking through it. I'm not going down the herd immunity route at all. I'm just pointing out the sort of maybe an argument there needs to be about endemicity, because that is in the title of this, no?
Yeah.
Yes. Go on, Dennis. You framed it, and we have flexibility to frame it as we wish, of course, when we actually come to writing it. But I think, Dennis, if you can talk about how you saw this section of the collection.
Yeah, I mean, I suppose there's I think the economics first. I mean, there's this discussion going on with started by Bernard Silverman about calling COVID a wicked problem, meaning that it's in a sort of area of taking decisions where, in the economic case, there are arguments, depending on how you do your calculation of the economics, there are arguments that getting rid of COVID is roughly as expensive as letting it go on the usual sort of estimates of the value of a life, or good quality of living years, or however one does the trade-off. And of course, it's a bit different, I suppose, from the usual NTD sort of situation, where yeah, so so I think that I mean, I think again, I mean, I'm trying to get my head around the question of whether the very interesting examples of elimination of the HAT and the filiaris, whether these are comparable with the kind of thing that goes on when, say, you eliminate COVID in a country, or whether they're really, for some reason, in a different sort of area, either in modelling or because people view the economics differently. I mean, you know, one feels in a logical sense, one ought to think of them on a fairly equal footing, but I'm sort of not sure if that's right.
If nobody else wants to chip in, I'll say that I do think they are, of course, they're different in dealing with a pandemic, you know, a new pandemic, you know, these endemic diseases, particularly these examples of the NTDs, but I think they're raising very questions that are the same if we're modeling a pandemic. Like if you know, start doing surveillance and you get a load of zeros, does that mean it's gone? If you know, if you're trying to understand what's the probability of elimination once you get down to a certain level, how important are certain parameters in determining elimination? So I think a lot of the modelling of elimination is relevant no matter what disease you're talking about. The economic balancing and what is the choice between endemicity and elimination, you know, it's something that we're grappling with in NTDs because they want to just keep them down at low levels. And, you know, that's actually quite hard to do. But we've got such slow epidemic growth rates for most of them that we can probably catch it before it gets too big. But that's not true for sort of a rapid global pandemic.
I was going to say there's a sort of static as against dynamic sort of situation. That's one difference. Yeah. Another difference, I guess, is with a new disease. Part of the economic calculation should be, if we let it, suppose we decide that in the first instance, perhaps it's a slightly milder disease than COVID, in the first instance you put up with it, then you're in danger that if it then becomes endemic, it might mutate into something worse, and or that the problem of getting rid of it later on may actually be more expensive than dealing with it first off when you have the chance. And it would be interesting to sort of tease out the parameters that make the difference there. I'm thinking, for instance, you know, if you had a disease that's incapable of evolution for some reason, or has very, very slow evolutionary rate, then postponing it at least isn't going to make dealing with it harder, which it might if it's a more changeable disease. So it would be nice to. It would be nice to just be able to classify the sort of, you know, I think there are several different dimensions we're looking at here, aren't there? It'd be nice to sort of set them out clearly and maybe see if there are things you can say about why some of them are more tractable than others or whatever.
Yeah, good point, Dennis. I don't know if anybody else wants to add to that. I'm going to stick in that we should perhaps look back at the early modelling of HIV as well. I mean, it's a slower epidemic growth rate than COVID, but it's faster than some of these things we're looking at. And, you know, some of the same.
I was just going to add HIV as an example, Deirdre. So yeah, I support that.
I suppose there's examples, of course, of whether diseases can be kept localized either in terms of the countries they're in or in the terms of the parts of the population they're in, where, I mean, HIV, I think, has shifted maybe more than once as between which parts of the population it's causing greatest havoc in.
And another analogy is antibiotic resistant strains of common bugs.
Well, yeah, sorry, that's sorry, that's the other side. When I was saying diseases might get difficult to deal with later on, it might not be because anything particular changes about the pathogen itself. It might be that whatever we use to deal with it develops antibiotic resistance or some similar problem.
Sorry, go ahead.
I was just going to say, I'm aware that Kirsty's on the call and we haven't heard from her, and wondered if she wanted to say any unformed thought. Kirsty, it doesn't have to be anything deep.
Sorry, I feel like I've gate crashed and I found it really
No,
interesting.
not at all. No,
it's not.
Please,
but
everyone's welcome.
I guess it's true if you don't know what it would look like in an endemic state, you know, or the seasonality, or it's very hard to compare costs as well. And I guess we're learning about that all the time, but and possibly have better feeling now for which subpopulations it would circulate in based on immune response or severity of infection at the first time. Yeah, that. Sorry. I was being left alone. But
No, but it's good to have someone who's not thinking about these things all the time in the room. So thank you, because we think about elimination a lot, and this definition of elimination as a public health problem, which is basically low-level transmission. Maintaining low-level transmission is a real challenge, and it's interesting that it's exactly what's happening with COVID. It's really hard. But your point about populations, I think, is really important. So which populations are, and I think in the second wave, although we don't have that much data, there's some data from REACT. Once again, we see high prevalence in certain population groups and in certain ethnic groups, social groups in the UK. So I'm sure that's true in other settings as well.
Coming back to specific diseases, another thing, I guess, is how difficult or easy screening is. You know, if you have a disease where people come out in large purple spots or have very obvious symptoms, then screening is much less important than if they've got a concealed worm burden that is, you know, gradually causing them damage in turn and will get worse if not treated or whatever, and where they're maybe passing it on, or any kind of disease where you pass it on without displaying very obvious symptoms. So that's another separation. Yeah, I mean, how different, I mean, is it just a quantitative difference, or is there a qualitative difference between these NTDs in terms of when you get near eliminating them, you get sort of flare-ups where you suddenly realize you thought you'd eliminated it, but you find it's actually still prevalent in maybe a number of different areas, as compared with COVID, where there you are in New Zealand, you think you've got rid of it, and you suddenly find you've got some cases in Auckland and some more down somewhere else in the country. Is it just a question of sort of dynamics, you know, bigger R values in one case and more mobile populations?
I think like with lymphatic filariasis, when you're down at low levels or like perceived low levels, I think a lot of the time there can be like hidden pockets of transmission if your surveys have been incomplete. So if you haven't targeted the right areas or the right populations within those areas, so you might believe that you're very close to elimination, and then not realize that actually there's a large number of people that you haven't surveyed who are infected.
And I would say they're not looking hard enough in some cases as well. So they don't even know.
No,
So
for some programs, success is to find no cases, which can be a motivation to not find cases, even if they do exist.
Well, of course, that kind of thing comes into perhaps some sort of policy discussion, because, you know, one of the problems with pandemic is precisely that, where the kind of people who should be sounding the alarm may feel that it reflects badly on them, or, you know, like in China, I mean, the COVID case, where the local health officials felt it reflected badly on them to say that they had a pandemic, so they hoped it would go away for a number of weeks, which of course allowed it to get much more serious.
yeah, the perverse incentives in a system like this are quite strong, really. So we particularly find that with things like leprosy. So, you know, you don't want to be the block that finds extra. You don't want to be the like the district that finds loads of leprosy cases. So, you know, if you don't look hard enough, then you won't find them. So there's a dramatic drop in leprosy cases globally, I think, from between 2000 and 2005. And it's thought to be because they redefined what a leprosy case was and removed some active finding programs. Because everybody missed the 2000 target. And yeah, I don't fully know the details. I think there's a paper called "The Missing Millions in Leprosy." I think that's it. Describes that situation.
I mean, there's a sort of political question in the economics here, isn't there? That yeah, ideally, the decision as to whether it's worth eliminating a disease. I mean, suppose we imagine a kind of mild sort of respiratory disease that just makes you come out in purple spots and laugh a lot and does you very little permanent harm. You know, we might decide that we can put up with that, and as you perhaps increase the seriousness of the disease, it gets to a point where you think economically this is worth dealing with. I mean, I think in the present case, you know, there are certain sorts of flu where for ordinary annual flu, although we vaccinate people against it where we can, on the whole, we've taken the attitude, I think, that flu is mostly not terribly serious disease and we can live with it. And then occasionally you get a more severe variety of flu, like the Spanish one, or I think the 1958 one, was it, where it has a death rate of 2% or more. And you realize that possibly only in retrospect, that really that would have been worth mounting the kind of campaign against that we've done with COVID. So, but that's the sort of rational case. But there's the not so rational case where, you know, some of these diseases that if they were widespread in the USA or the UK, you know, they wouldn't be neglected.
Yeah, and I think with the NTDs, quite a lot of not all of, but a reasonable number of these diseases used to be endemic in places like the US.
Well, I suppose it's the other thing that people just accept that they are endemic, don't they? Maybe hopefully one of the good aspects of COVID is precisely that we're having this discussion, that we're sort of thinking, if it's worth dealing with COVID, and we look at our economic calculation, how many human lives you save by whatever, and the cost of it, we might actually look and say, well, actually, there are several other diseases where we would get more value in terms of lives saved for our money than COVID.
I think it's a very difficult calculation.
Yeah.
Yeah, but
yeah, and I think for some of the NTDs, the calculation is exacerbated, like the difficulty of the calculation is exacerbated by the fact that there's not like a clear death rate, or there's not a clear impact. So things like lymphatic filariasis aren't, it's the mortality isn't a mortality rate, really. It's not going to kill you, but in some small portion of people, it can result in debilitating, permanent, lifelong disability. And it's very, very hard to account for how that weighs up against other things.
But you know, but I think it would be good to include in challenges something about sort of when is it economically sensible to eliminate a disease. I mean, I can imagine a sort of graph a little bit like the famous one of Christoph Fraser and Co. with the Arnold and the asymptomatic cases, where you might have a sort of trade-off thing that says, with some kind of curve running across it, perhaps a couple of roughly parallel curves depending on how you did it, that said if it's in top left of the graph, it's definitely worth eliminating, bottom right is definitely not, and quite where you draw the boundary is arguable depending on your value you put on life or whatever. But then you might on top of that put the data on a number of diseases, and I think you would probably find that there are several diseases that are in the wrong part of it, that maybe in the one direction that, you know, you can imagine there might be a disease that people are spending a lot of money to eliminate where actually it's hardly worthwhile, and probably more often there are a number of diseases where it plainly would be worthwhile to eliminate them, but the effort is not being put in, or, well, as I understand it, in terms of development in recent years, perhaps the effort is beginning to be put in. But so I think that's a challenge, but the probably scientifically more interesting or more important challenges to do with elimination.
Could I just ask, and I do apologise for having missed about half an hour, so I may be asking something that you've talked about, but is there, you know, if you're talking about when it's economically worth trying to eliminate, which of itself would overlap with the economics challenge, but is there a sort of halfway house where you don't want it to run sort of free, as it were, endemic but at a high level, but sort of endemic but at a low level by control? So, I mean, presumably there are levels of control that can be applied from, you know, just let it run, to we don't want more than a certain number of deaths. Is that ever a policy that is worth thinking about?
I would say definitely for COVID, right? That's definitely the part of the conversation, is what can we tolerate?
Yeah.
Could we tolerate a drip? Yeah.
Yeah, exactly. But is that a strategy that's adopted for other things, that as long as the endemic level is low enough, then we tolerate it?
Seems to me for COVID, it's an argument that appeals to politicians, which I'm personally very skeptical about whether it makes sense. You know, I mean, politicians, particularly our government in the UK, seem very keen not to do more than they absolutely have to in terms of lockdowns and restrictions. And whereas it's quite possible, if you think about the simple dynamics of epidemics, that really taking a rather higher cost in the short run might actually allow you to really get pretty much eliminate it, and it would therefore be much cheaper in the long run. You know, I mean, why have a intermediate policy that maybe, you know, costs 75% as much as eliminating, and have that essentially being committed to that permanently, when if you put in the 100%, you could actually get rid of it. I mean, I know it isn't as simple as that, but I think actually that
I think this ties into a lot of what we talk about in NTDs, which is that elimination is really a global target. It can't be a local target.
But I think with some NTDs, I mean, you know, my suspicion is that, let's say, malaria might be an example where you can sort of half deal with it. You know, if you drain lots of swamps or whatever it is, you may be able to get malaria levels down lower. I mean, certainly what's happened in England. I mean, there's the south coast around Sussex. There was notorious, it's near Rye. There's a notorious marshy area that was a real hotbed of malaria. And I assume that what they eventually did was they drained it and malaria went away. So, you know, that kind of thing, it's a kind of disease you might, I suppose it's a kind of disease that has a geographical factor to it. So you can deal with it in some areas and not in others, which I mean, COVID, I don't think is like that.
But even with malaria, like, you have to maintain your measures. Like, even once an area has reached like local elimination or is very close to local elimination, you've got to kind of maintain your vector control measures and maintain your surveillance. Because in malaria, we've seen like examples like in the 70s where we made like huge grounds to eliminate malaria, and then everyone was like, this is great, we've made all this ground, and then you saw huge resurgence afterwards. Because the measures weren't maintained, and the maintaining of these kind of control and surveillance measures, even when you've essentially eliminated, is often almost as expensive as, because the number of people you need to sample to make sure that 0 is 0, it can almost be as expensive as bringing the numbers down.
All good points. And I think Mariam also illustrated that for HAT, right? They made huge progress. They lost its, every elimination program has gone through that cycle, right?
Exactly.
So I think we always underestimate how hard it is to eliminate. It gets really, really hard towards the end. Every elimination program has these massive long tails. It's really hard. And I think you generally underestimate the effort required. So I suspect it's the same for COVID. But I don't know whether it would be a serious policy in the UK to eliminate COVID at this stage.
Yeah, I think for COVID, like my feeling is that for COVID, because it's so easily transmissible, and because people can transmit without having symptoms, and the fact that it spreads so quickly between countries and across the globe, and it's really hard to limit international travel, even when it's highly reduced as it is at the moment. If we manage to completely eliminate it in the UK,
some countries could do that, like China could do it to a very great level. So it's completely under control in China.
Because they can test 10 million people in a city like daily or something crazy. Like, it's amazing the response they're able to do when they get cases.
But they're maintaining that infrastructure and that cost. They haven't eliminated and then been able to take away that infrastructure.
Yes, exactly. The costs don't go away either. That's exactly a really good point. Yeah. It always looks more attractive. Yeah.
If we completely eliminated COVID and then packed up track and test and trace, it would just come back.
Well, it's an interesting guess as to where we're going to be in, let's say, 12 months' time. Will we still have a number of countries that have eliminated it and that are, it's a mixed bag of China and New Zealand and possibly Vietnam, Taiwan, a few more like that, and a whole lot of other countries. Well, I mean, where are all the other countries going to be? Are there some that have going to really gone the whole lot and herd immunity, where 2/3 of the population have had the disease?
With short-lived immunity.
What are the political and economic choices going to look like at that stage? Is there going to be any proper international negotiation over it? Look, let's all agree to do the same thing. There's been very little sign of that so far, isn't there?
I think a lot of countries can't afford to target complete elimination.
Well, they may decide in the longer term they can't afford not to.
Mariam, you were speaking.
Oh, I just said even Europe could do some effort to do it. Even, I mean, at least at the beginning, and they didn't come together. It was very shocking to me as a union. They didn't try to do something.
But then I guess they did some things. But you bring to my mind that vaccine programs are in some sense cheaper. Long-term vaccination programs, it's easier to think about elimination because you don't have to vaccinate everybody every year, right? So you can. It's still very challenging to eliminate these because they've often got very high R naughts, these childhood infections mainly. But yeah,
it's one of the suggestions that Andy Dobson put forward as one of the challenges when we were discussing the economics session, and looking at the cost benefits of vaccination versus treatment.
But if you had an effective and safe vaccine, then it gives you much more valid. I mean, New Zealand, let's say for a start, could just open its borders, but say you're only allowed in if you've got a vaccine certificate.
Well, that's less than 6 months old or something.
Yeah, well, depending on depending on how long the vaccine is thought to be effective for.
Yeah.
So, I mean, that would certainly, I mean, if there is, that will, if it happens, make I think, a huge difference to how realistic it is for a country on its own to try eliminating it. Because you can then go about fairly normal travel. I mean, presumably, if one has a hypothesis reasonably safe and effective vaccine, it would be reasonable to, I mean, say in the UK, you could demand everyone coming in and get back to the normal high levels of international travel we have.
Depends how effective the vaccine is.
Well, that's my point. I'm saying it's quite possible. It's quite possible that vaccine
Yeah, that's a lady called
not
Kirsty.
sufficiently effective or not last long enough or whatever. But it seems, I think it's worth thinking about because it's probably the most realistic prospect of short term, being able to eliminate it country by country in the short term.
Yeah, I certainly think elimination without a vaccine is basically impossible.
So I need to go at 12:30, and I said I would chair, and I also told Miriam and Emma that it would finish 12:30. So before I go, should we just do a bit of housekeeping around how things are working for these challenges? I noticed that Kira is managing the Slack channel. Do you want to say anything, Kira, about how we're managing keeping these moving and what are next steps and things?
Yeah, so what we're doing is we've got the Slack channel set up. I will post a link to the discussion session, the recording of this on the Slack channel, so people can watch it back and take some notes if they want to. And then we've just been trying to encourage people to put sort of additional challenges or any thoughts that they have in the Slack channel, which we will then use to start trying to collate some kind of document on the challenges. So if people can kind of just put things down in the Slack channel as a first port of call.
I'm assuming this Jamboard remains in existence. Can we have the link to that in the Slack channel?
The what?
The Jamboard.
I put one in the chat. Yeah, it's like mural.
Oh, okay. I haven't got
don't
that.
worry, I went off piece. Don't worry, it's in the chat. I think you'll probably get it.
It's in the chat.
But,
oh,
yeah,
so I've only got the chat from when I've been.
So we haven't got, because
Sorry, just
Kira
to
and I
say,
disappeared, we haven't got the chat.
and sorry, just to say, on the Slack channel, we don't yet have a channel for this.
Oh, I've just set it up like
Okay.
2 minutes ago. Sorry.
It's not come through, but yeah, I'm open. My Slack is open, so that's why.
Oh,
I'm sure it will come in a second, probably.
I think it's because I haven't invited you yet, Jasmina. What's your what are you on Slack? Are you?
It's called Jazz, J-A-S.
Okay, yeah.
I tried to change it, but it's still JASG.
That's fine. I've just added you.
One thing I wanted to mention earlier as we were discussing, but the conversation was going very well, so I didn't want to interrupt this, is the linkage potentially of this part to other parts. And I definitely see linkage with the modeling section, modeling chapter, where we specifically would discuss different stages of the epidemic. And the question would be whether sort of an endemicity at an early stage of the epidemic can be considered an elimination, and how does that change through the stages of the epidemic, or if you have a fragmented epidemic. I mean, this hasn't been written in the modeling chapter yet, it's currently in my head, but I think I see a parallel drawing there, and just noting it.
Yes, and Valerie already drew out some overlap with the economics paper, so I think we'll have to obviously rationalize that as we go, but it's good to have a bit of free thinking, I think, at the minute.
Absolutely. No, I think the aim is to put everything down. It doesn't matter if it ultimately ends up somewhere else, or so other things get joined to it or whatever. The main thing is just to capture all the thoughts.
I mean, absolutely. I mean, I think that's what sort of overall editing is supposed to do, is to say we've actually got a challenge in eliminating this theme and another, and we've got the same challenge popping up in some other section, whether it's modeling or economics, and then just to look at it overall and say, which does it fit in best? I think it's very unlikely you'll be having exactly the same thoughts as people in the rival channel, so I wouldn't be put off by worrying about duplication at this stage.
But
the slant will always be different.
Sorry, but do you agree about this point that the term elimination becomes endemicity at certain level of prevalence or incidence, or in a certain fragmented style epidemic?
Well, I suppose that's there's the question of local elimination, I suppose. So if it's fragmented, but it's not quite the same, is it? Because if it was fragmented, you're getting sort of local spikes that could be anywhere. Whereas if it's locally eliminated, you're not expecting, there are regions where you wouldn't expect a local spike. Does that make any sense?
Yeah, yes, but I'm more thinking, so you have, if you knew that they were just low, it's fragmented, so you have local spikes, you know where to go and do other things like NPIs, and therefore conquer it that way, like China does on a global scale. And that's why I think of it as, okay, so maybe potentially eliminatable rather than eliminated.
Yes, I suppose so. If you could really zap the spikes well enough when they appeared, that would be
And
go in that direction.
Sorry, I'm taking you in a different direction from there. Then sort of the idea, I think, emerges of a circuit breaker, and the challenge that why that may work is because it will kind of reset the epidemic, right? And then you could do equivalent to what I just said on a more global scale. I mean, I don't know if this is tangential.
I'm not sure. I think I didn't get your original point, actually. So you're saying, you said endemicity is elimination at a different. So yeah, say it again, please.
So the point being about when can we, at some point of either stage of the epidemic or level that it is prevalent or has incidence within a setting or within more subdivided settings, can they be analogous? Can endemicity be the same as elimination or potential elimination? And the way I think of it is that you sort of have a system by which you reset your epidemic, and analogous to how, for example, a circuit breaker would work. And then you can do other things like China is doing on a global level with testing, with tracing, etc. Because then you have less numbers to deal with. But the economics component will be important because resetting the epidemic will close the economy in a sense. The silence worries me.
I think because I'm slightly distracted, I don't fully get your point, so I'll null it personally. But
okay,
feel free
maybe just leave it to think through and to sort of maybe just put it as a note and we think through, but to maybe expand on it.
You must put it as a yellow sticky on the Jamboard.
I haven't got the thing downloaded. I need to download it and do it. So if somebody can do it,
it's just in the chat.
Oh, you can do it online. Yeah, you can do it online.
Can you?
Yeah.
It's just
a web. Yeah.
URL link in the chat. But it's the most recent thing in the chat.
Yeah.
Yes, but it doesn't allow me. It says I have to get the app. Okay, I need to do that.
I didn't get an app. I just clicked on it.
No, just opened, like a Google Doc does. So
yeah, that doesn't work for me. Maybe it's because I'm using my phone. I don't know. I'll have a look. Sorry, I'm gonna stop talking because it's 3 minutes to go, Deirdre.
No worries. Good. So, well, I thank everybody for their time, and particularly Emma and Mariam for their presentations. I think that was really helpful for starting the discussion. So, and thank you for all the children. I can see another one who attended and gave important contributions. So I think, so our next steps, Kira, are to come up with a specific, a half page or a page of a challenge in this area that we think is important. Not as in don't write the whole thing, just think about which one or two or three or four that you'd like to contribute and put it in the Slack channel, and we'll try and build them out from there, right?
Yeah, and if one person, maybe one of the ECRs, would like to kind of volunteer to coordinate the paper, that would be great as well.
Yeah, and I think
the ECR being early
Early
career
career
researcher.
researcher.
Yeah.
you're all supposed to have lots more time on your hands. I don't know what to do. I mean, I think an obvious thing to do is to take everything that's been put on the Jamboard, plus any other notes you've taken or whatever, and just try and put them into a single document.
Yeah, but it doesn't. The issue is that it doesn't have people associated with them. So we will, compile them, but we need to pin people down.
Well, I think, but I think
Yeah.
if someone puts them roughly in order in a document, they might sort of identify that some of them really are pretty much a challenge. You know, that they're given it a clear sort of research challenge comes out of their wording. Some of them may not. Anyway, it just seems to me there's lots of good ideas in there.
Yes. No, we should definitely capture them. I agree, Dennis. Fantastic. I'm going to head off.
Okay.
But thank you so much for your time.
Thank you, Gigi.
And Kira will keep us on the straight and narrow. And if anybody feels like volunteering for things, do get in touch.
Thanks, Deirdre.
Bye, everyone.
Take care. Bye-bye.
Bye. Bye.